All right. Hello again. Hello, hello. So now we will talk about another topic that is liquid biopsy. So what liquid biopsy is effectively a test that is accessible test that can measure something in body fluid. So actually the history of liquid biopsy is quite long. So the first time liquid biopsy was described in literature was in 1890 or something, where they actually found circulating tumor cells in a human patient with metastatic breast cancer. But it wasn't really used in the human medicine until more early 2000s, when they first found that you can identify mutations in the circulation of patients. So the advantage of liquid biopsy is that it's minimally invasive, so you don't need any invasive procedure. What you take is blood, or you take a fusion, for example. It's quick and easy to perform, and it's very sensitive to detect cancer, depending on the technique, of course, that you use. But just to kind of, it doesn't really work in here, but there are lots of different techniques that were described. So you can search for circulating tumor cells, you can search for DNA, you can search for RNA, proteins, antibodies, just as Dr. Tam was talking about, and that can be used for early detection of cancer, can be used for surveillance for micrometastatic disease, or actually to see what type of treatment can be used for the patient versus instead of using the tumor sequencing, use the liquid biopsy instead. And also, what is important is you can actually identify this way early measurements of any kind of resistance to treatment, even before you see that in the patient. No? 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 Okay. So we have different scenarios of use of the liquid biopsy, and I think that's important to kind of think about from its use. So you can have screening. So essentially, a healthy dog comes into the clinic, and you check out it's at a high risk of cancer, or the owner is worried about the dog having potentially cancer. Usually, when it's sick, then you will have aid in diagnosis. But overall, it's kind of like a healthy dog comes in and has a test done, right? And you have different tests for that. So one of the most common is NuQ. I think I talked with Tom that actually it's not yet available in Brazil. You have some tests that are available or were available in US, such as Oncotect, Medical Arc, which is actually a Japanese one. So the Calviri peptide test that Doug was talking about. We have IDEX Cancer DX, but that can screen only for lymphoma effectively at the moment. And there used to be a test called from PetDX called OncoK9. And then you can use it as an aid in diagnosis. So you have a dog that you want to diagnose with cancer. It's difficult because of the location, or difficult because of the patient. And then for monitoring or treatment selection. And that's kind of the platform that we developed. So you can use different, just as I mentioned in the previous slide, you can use different things to actually detect cancer, right? So we have metabolites of the cancer. You can have cell-free DNA, microRNA, nucleosomes, and nucleosomes is something that NuQ is working about. Antibodies, so what Calvary is working about. So probably NuQ, as it's kind of endorsed by lots of different companies, will come to you at some point. So just wanted to quickly talk about this test. It's developed by Oncologia Veterinária, and it's blood-based test. It detects actually nucleosomes in the blood. It's designed for screening, and it has one of the problems of this test is though that it can be increased by inflammation, especially in patients that are elderly with lots of different coexisting disease. You can have a false positive results. So, and of course, it works very well in disseminated cancers, but less well in actually localized cancer. So if you can see from the initial study, in majority of cases, you have about between 77 and 54% detection rate, and the specificity is about 98% for virus cancers. But we've selected to work on circulating tumor DNA. That's the best established test effectively in humans. So what you do is when cancer cells die, they release into circulation some DNA that can be then detected using sequencing. What the advantage of this this kind of assay is that what you see in the blood is actually in real time. So in humans, they measure that actually you can detect the mutation in between 25 to 2.5 hours in the patient. So it's a real time kind of monitoring. So if you would run a CT, it's almost the same time as you would have at that time mutations in the circulation. So they come from apoptotic necrotic cells or via active release. So the key why many people selected DNA to work with rather than other things is probably that, the stability. So DNA overall is a stable molecule compared to RNA, for example, although us and others recommend special stabilization tubes. So I have just a tube to show you here. So it's just like a regular blood tube, but it has a bit of a liquid in there. We can just put it around. I can give you another one somewhere. So the advantage of using those tubes is that it stabilizes the blood for up to 2 weeks. So then we don't have to worry about refrigeration or spinning it down or anything like that. There is a stabilizer inside that stabilizes them for up to 2 weeks. So it's good for transportation and up to 30 degrees, which is probably important in Brazil. Right? The thing in humans why they selected this molecule is also abundance. So it's very abundant in the circulation of humans with cancer in majority of cancer types. It's a little bit more problematic actually we found initially in dogs, but it's good enough to actually get as much as we need. And then all the DNA sequencing and mutations are well established in humans. So then we can actually use this and find the mutations in the circulation. So what we use for testing frequently or as kind of to monitor the disease is actually what is called the variant allele frequency. I will talk about it quite a lot in the presentation. So just to let you know what it is. So effectively it's a percentage of the mutated variant reads in all of the reads that were kind of done. So if we would have a germline mutation in anything, it would be around 50%. If it would be heterozygous, it would be close to 100% if it's a homozygous mutation. But in somatic mutations, so the cancer derives can be all over the place effectively. And what we use it for is to monitor over time how the dynamics of this variant allele frequency changes with treatment. And that works quite well independent of the species. So just to talk to you about the test that we are doing. So it was validated initially on 246 dogs. We did over 500 cases right now, close to 600 actually. It was tested across 35 different tumor types. The sensitivity and specificity with the machine learning module that we added to it is about 90% for both and up to even ideal actually. And when we look at the mutations, when you look at tumor samples versus healthy, there is a clear differentiation. As you can see, there are the median for healthy is 0. We have a few outliers that actually we couldn't test log later on. Looking at the mutations, probably they had cancer, but just not detected at the time. But we lost them to follow-up. And you can see clearly in the tumor samples, we see also more copy number changes compared to when in the tumor group versus the healthy. You can see, I don't know why it's so kind of weirdly showing blurry, because on PowerPoint it wasn't, but it's fine. So we have different tumor types in here. And you can, if you could see, although you cannot see, in majority of tumors, we detect above 80% or 90% of cases. The one where we don't see any, we didn't detect any was actually an oral fibrosarcoma. So majority of those are, in the samples above 10 samples where we tested in tumor types, the most frequent one, the detection is always above 90%. And what is important is you can also use liquid biopsy in a different way. There is one case in here that was actually, based on pathology. It was a benign proliferation in the nose that actually finally killed the dog, but it was theoretically benign. And we found in the circulation that it had the signatures of osteosarcoma. So maybe it was more kind of like an early stage osteosarcoma, and this is where, or like a low grade osteosarcoma that grew over time. And this is something that, when we mentioned about tumor sequencing, how we can differentiate actually between those hard to diagnose cases that, clinic doesn't match the pathology in some of those cases. So where can we use this in clinical scenarios, right? Because this is what is probably the most interesting for you. So first is, to screen or not to screen. This is the question, right? And this is a difficult question, and I will show you some cases why it is difficult. Then we have aiding diagnosis. So some of the cases where, you have a mass, let's say in the lung, it's very close to the heart, and of course, FNA is risky. You want to have, the owner really wants to have the diagnosis. Looks like cancer, but you cannot confirm it in different ways. To make some post-operative decisions, and we get quite a lot of those cases actually, some treatment decisions to identify early resistance to either chemotherapy or targeted therapy. So screening is something that our test is actually not designed for, and the reason for that is that it's very sensitive. So what we know in humans now, just a recent paper from probably 2 or 3 months ago, was that they found that actually in humans you can find mutations 3 years before the cancer is being diagnosed. Right? So if we take it into dog years, probably that will be half year or something like this, but that's actually quite a lot to stress the patient about it. And one of the key questions that we were asked initially when we were looking into how to position this test was, what do I do with this patient, right? Because with the test that we are doing right now, in majority of cases, we cannot say what type of tumor it is. We can say yes or no, potentially it's this or this, right? So this can be challenging because that can affect how you will later on treat it. And of course, we don't know a lot about the breeds that are still predisposed to cancer. Maybe they actually develop it over a long time, but we just don't see it, right? So this is a challenge. And this is one of the cases that was sent to us actually as a screening test. So 6-year-olds, of course, classical Bernese mountain dog, it cannot be different, right? Had a whole body CT, no tumors were found. Liquid biopsy in the first time point, there's quite increased amount of cell-free DNA. That already tells us something because it was about 4 times more than we usually see in healthy dogs, which sometimes indicates something as well. And there were 3 mutations and 3 copy number variations in that, where you look at, if I will show you the slide before, usually on average we see about, if we see any, then we see 1 mutation in a healthy animal rather than around 3. Then we had another time point, and at this point it was whole body CT, nothing was found, right? Second time point, 3 months later, very high amounts of cell-free DNA, 20 times more than in a healthy dog. More mutations, lots of copy numbers, there's no trauma, nothing like this. But there are still increased numbers of cell-free DNA. Another whole body CT, nothing really found. So that's something that is challenging, right? And then we have now another time point, and we have increasing amounts of certain mutations that are, we can follow over time, and they are increasing, but still we cannot detect it clinically in the setting. And that's what we see also in clinical patients sometimes, that let's say there is an incompletely resected mass that we know that was incompletely resected. We can follow those mutations over time. You cannot detect it in imaging, but we know that there is something brewing in there at the same time. So now to talk about aid in diagnosis, and probably many of you face the same challenges as people in Europe do or anywhere else, like how to really diagnose some of the challenging effusions. Because like this case is probably something that you would look and okay, it's mesothelioma, it's fine, right? But this was not from this case, of course. So this dog had kind of everything done diagnostically, whatever you could. So the dog had, disseminated lesions in the peritoneum, high amounts of peritoneal effusion produced. There was cytology, histopathology, immunostaining. Multiple pathologists looked at it. They initially were thinking, okay, is it malignant or not? And they couldn't actually decide, but then they thought, okay, cancer is more likely. But then differentiating between a carcinoma and mesothelioma in this case was not a clear cut either. So we actually did sequencing of both the cell-free DNA and the effusion in this case. So in the blood, we confirmed that it was cancer, but we couldn't differentiate between the two. Then we sequenced actually the effusion, and we used our tumor sequencing panel rather than the one that we usually use for the blood, just to have a larger scope. And then we found that it's likely a carcinoma, and there are multiple potential targeted therapies were identified as well. So then the cardiac neoplasms, sometimes it's relatively clear cut, but sometimes it's not, both from a fusion perspective as well as location and stuff like this. In this case, the location was suggestive of hemangiosarcoma. So we did again sequencing of the fusion, and we found some mutations that are classical for actually hemangiosarcoma. So this dog was kind of based on this had high likelihood of having a hemangiosarcoma. Now, from effusions, probably the easiest way to differentiate right now at the moment with the data that we have is between hemangiosarcoma and not hemangiosarcoma. But this is something that we are trying to work on to differentiate between different tumor types. And then, of course, the liquid biopsy can be used in different scenarios, right? So in this case, it was used as an aid in diagnosis. So the dog had 2 years before, had a mammary carcinoma removed, then comes out for another recheck, and they found a mass in the chest. That is kind of slowly growing, but they are not sure what it is, right? So we did liquid biopsy, and we found mutations in the circulation, suggestive of a neoplastic process. It could be carcinoma, but it was kind of like a mixed result between carcinoma versus osteosarcoma, or what it really is. So then they repeated actually the whole body CT scan and found a 6 millimeter mass in the mammary gland, which came back again as a carcinoma. And what you can see in here, this is the tumor sequencing. This is the plasma for the first time point that we collected it, the second. So you can see that some of the mutations match the mutations in the tumor, right? But there are some other ones that are not matching it. So definitely there is something still going on. So probably the mass in the lungs is independent of the primary mass that we found in the signal from initially. And then we can use to guide our perioperative and postoperative decisions. So first question is how to treat, right? And the problem of mammary carcinomas and soft tissue sarcomas, which are incompletely resected, it's always difficult to decide, should we actually follow up with treatment, or should we leave it aside and see what kind of happens? So whether there is an opportunity to actually de-escalate some of those treatments and leave it and just drop it. Whether to treat it or not overall is a discussion on various different cancer types, right? So from mast cell tumors, soft tissue sarcomas, again, mammary carcinomas. We can use it for minimal residual disease monitoring. And for minimal residual disease monitoring, what you can use is you can use a tumor-informed approach where you sequence the tumor and then you follow over time. but that's not always necessary, depending on the cancer type. So usually, also because of the costs, we use the tumor agnostic approach, where we have at point 0 and then we follow it on over time. And as with anything, we kind of need more data, because one of the things that we know is in humans, there are certain cancer types that are shedding more cell-free DNA versus shedding less cell-free DNA. This is some data that we still need to collect, but we have some indications that, for example, bladder carcinomas are not really shedding that much cell-free DNA compared to others. Similarly to anal sac adenocarcinomas, for example. But why postoperative measurement is kind of important in humans, and we know that there's some data out there from PetDx that it can be actually quite important for dogs as well. So across different cancer types, and this is one of the papers, but there are lots of them actually, and they say the same thing. If you have a cancer and after surgical resection, you don't detect any tumor DNA in it, then the patient is kind of really cured, versus the ones where you do detect it, they die much quicker because they still have residual disease. And I think where the field is heading in humans as well is that what they do is they start looking into using cell-free DNA as a biomarker on which patient to treat versus which patient not to treat. And this is actually patients with stage 2 colorectal cancer, where they enroll them in either a standard of care, where they follow the normal guidelines, or they do a circulating tumor DNA informed approach, where if they detect circulating tumor DNA in this patient, they treat the patient. If they don't, they don't. And what is important is 50% less chemo was given, while the survival is essentially identical, which is, I think, quite important for the, in our field as well, where we could actually help many of the patients not to go through potentially treatment. So now for some postoperative decisions, right? So this is a 10-year-old male-neutered whippet with soft tissue sarcoma on the neck. Actually, what is interesting is when the blood was first time sent to us, and this was one of the first samples from this case. It has actually lots of different mutations, as you see there. And it was one of the first samples that was sent to us. And the oncologist from Paris told us, you know what, guys, this was growing for a very long time. It's impossible that it has so many mutations. It doesn't make sense clinically, right? Then they resected it, and it came back as actually a high-grade soft tissue sarcoma that was kind of infiltrating into the neck. So the dog underwent lots of marginal surgical excision, intraoperative radiation, plus an external beam radiation. But you could still see that there are actually, the number of mutations decreased, number of copy numbers still remained almost the same. And as you can see in here, we had one variant in CDKN2B that we could actually follow over time. But it's interesting, at the second time point, we found a mutation in PTGFR that could be targetable, so could activate PTGFR. So the dog was started on masitinib, and 6 months later, we couldn't find any mutations anymore. And the same with the CDKN2B. So the CDKN2B. And then this is an eyelid melanoma in a 5-year-old Rhodesian Ridgeback. So again, it was incompletely resected. The dog had also previous history of lymphoma, so the owners wanted to potentially investigate whether we can follow up both, right? We found some mutations after the melanoma, we suspected. And again, my colleague was thinking like, Maciej, it's impossible that you found something. It's like almost impossible. So I told her, let's sequence the tumor and then let's see what we can find. And you can see that this is probably the most kind of interesting. So we found multiple mutations in the tumor, right? In the initial time points, we could find the tumor mutations in both in the cell-free DNA as well as tumors, and the numbers are increasing over time as well. So you can see how we can nicely kind of monitor. The challenge is, of course, now at what point that will show up as a tumor as well, right? Whether to intervene or not. The owner were really reluctant to do any treatment because then they would have to resect half of the face essentially from this dog. And there were some targeted therapies as well, but they didn't decide to do that at the moment. So from treatment decisions, liquid biopsy has an added advantage compared to the tumor sequencing because, as we talked previously, there is tumor heterogeneity in the tumor. So we don't really, if we sequence one piece of the tumor and the other piece of the tumor, we may have slightly different results, right? But the advantage of liquid biopsy is that it captures both the tumor heterogeneity as well as potentially the metastatic niche. So it will add us additional information that we need. The challenge is always the cutoffs, for example. So when do we prescribe specific type of therapy? So there are cutoffs that are known for the tumor. The cutoffs for cell-free DNA are not that well established. As with the tumor sequencing, the question always is it really a driver of tumorigenesis? But this is a challenge that we always kind of face. So just as I mentioned before, certain types of cancers shed more DNA than others. So maybe the cutoffs need to be tumor specific. And the matching mutations between the primary tumor and the cell-free DNA are around 70% or so. Okay. But what we know from humans, at least, is that driver mutations that are in the primary tumor of humans are also found in cell-free DNA. So some treatment decisions. This is like there was a 7-year-old flat-coated retriever, aggressive mass in the mouth, maxillary epidermoid carcinoma. We found the vet sent us a liquid biopsy to identify potential molecular targets. And just as I mentioned, you can there's a frequently recurrent BRAF mutation in this type of patients, and this is what we found in this patient as well. There is a loss of function mutation in NF1 gene and amplification in EGFR and different PDGFRs. So this would be a very good target, and it was started on trametinib for treatment of this oral carcinoma. And this is a deerhound with 11-year-old male neuter deerhound with a peripheral nerve sheath tumor. It had actually multiple surgical resections of the medial nerve in this case. And then it came one day and had, probably you don't see it, but there is some increased opacity on the CT. Now the question was, is it something that is just due to multiple surgeries? There's some seroma formation, or is it really a recurrence of the initial cancer that the dog had? So we did both tumor sequencing and cell-free DNA, and we found that there are multiple matching mutations between cell-free DNA and tissue. And the dog had also in the tissue, we found amplification of EGFR, which could be targeted. So the dog actually was sent later on for radiation therapy, but unfortunately, his disease quickly progressed. And then, some of the things that were some of the cancer types where I think it can do a lot of good is lymphoma. So we have, we clearly see that some of the patients have different ways of responding to treatment, right? So we have lots of dogs, majority of dogs follow this schedule. So we have at the initial diagnosis, we have mutations. Then at the first follow-up, they almost disappear. And then over time, or in this case, actually at the relapse, the second follow-up was relapse, you can clearly see that the mutations were, all of them came back. But some of them follow this way. So at the time of diagnosis, we have, some mutations, that are relatively low level for the level of actually, for the advancement of the disease. But then they actually, over time, rather than decrease, they increase in frequencies. And all of the cases that we had like this didn't even finish the CHOP protocol. They quickly died, even though at this follow-up stage, the dog was actually in clinical remission. And this is another interesting lymphoma case. So, of course, hepatosplenic lymphomas are difficult to follow up, right? Because you need frequent FNAs of liver, spleen, monthly, or however anyone kind of wants from frequency-wise. This one was actually an atypical B-cell phenotype rather than a classical T-cell phenotype. This was treated with CHOP, and we started monitoring actually at the end of CHOP protocol. And you can see that we had some background mutations in here. We didn't have at the very start of the treatment. We received the sample at actually finishing of the CHOP. In this case, clinically clear. And in this, the third time point, actually, from clinical perspective, the dog doesn't have any signs of relapse. But what we found is there are some mutations in here that are, TP53, SETD2, MAP3, K14 that are kind of classically found in mutations in dogs. That suddenly we didn't see them before, and suddenly we started to see those mutations. So we called the vet to say, hey, molecularly, it's probably coming back. Then actually, a couple of weeks later, the dog got back for a recheck, and it had clear clinical signs of relapse at this point, and that kind of followed what we see from molecular way as well. So that's a really nice case to illustrate that we can find things earlier. And then again, lymphoma, so this is a B-cell lymphoma, stage 4B, again, treated with CHOP. So at the time of diagnosis, we have certain mutations, right, that we found. Then at the last doxorubicin dose, the dog was in complete remission, but actually one of the lymph nodes, submandibular lymph node, was enlarged. And this is always difficult to think about what to do next, right? Especially when your pathologist tells you, oh, this is probably reactive. It's nothing really important. So in this case, the reactive lymph node, based on molecular diagnostics, would actually be called probably a relapse of the disease. But a week later, we could actually take another blood sample from this dog, and you could clearly see that the mutations went down, but never completely disappeared. We actually don't have actually the next time point, but it relapsed about a month later, like from clinical full-blown relapse. And of course, the lymph node after this one also shrunk. And then the mast cell tumors, just as I think I discussed with one of you, it's always kind of challenging to monitor, because whether we have some mast cells anywhere in lymph nodes, in liver, spleen, or anything else, that's always challenging, right? So we have, at the time of diagnosis, we have lots of mutations found in the circulation. It was marginally excised, it had palliative RT and Wim blasting treatment. But even at the follow-up after all these treatments that he got, you can clearly see that from molecular perspective, the treatment just had a really minimal effect on the most of the clones in the circulation, and then some of them actually grew. 1 month later, the animal was progressive from clinical perspective. And one of the things that, where they use liquid biopsy in humans is actually treatment resistance. One of the first tests that was approved by the FDA for using liquid biopsy is actually to look at EGFR mutations in the circulation. So what you can find is with EGFR, there's a certain types of mutations that are treated with first line of EGFR therapy. And they know exactly how, when the resistance will start with a specific mutations that occur upstream of the EGFR gene. So they found that if you see in the circulation those mutations that are responsible for resistance, you treat with the second line of therapy effectively. And this is something that we are looking at right now in mast cell tumors in particular. We treat them with Palladia, the high-grade tumors, and whether we can find actually the resistance mechanisms in the circulation. And the cats, as usual, we don't know. We are a lot to do. We are currently working on a cat test as well. So hopefully that will come soon enough to the market. Thank you.